Dear chairs, dear audience, it's my honor and a great pleasure to give this keynote. In the last years, we have experienced extraordinary times. This talk will reflect on the visualization research topics, output, and the working style before and during pandemic. When we talk about pandemic, we automatically associate it with COVID-19 pandemic of the last years. However, pandemics have affected mankind already for a long time. Recently, we also experienced the so-called quiet pandemic. This was the early motivation for my research presented in this talk. I will thus start with these days and then continue with the extreme change in 2020 up to now. Finally, I will also summarize the lessons learned and the way forward for future work. The talk will build mainly on my personal experience as a visualization researcher and as a human being. Nevertheless, I hope that you can relate to it, as I believe that many of us have experienced similar situations and similar work. The talk will show many examples from visualization research, inspiring my work and the work of many. It's only a tip of the iceberg with selected examples from many works. There are many great resources, papers, books on similar or related topics that complement this talk. I highly recommend you to read and digest them. This talk and the presented work would not be possible without my co-authors, my colleagues, students, cooperation partners, and the broad research community that supported and inspired this work shown in the keynote. I thank you very much for that. Let us start from the time when I became interested in this field. Let us go back to the year 2017, the period of the so-called quiet pandemic. Antibiotics are an effective means to treat diseases caused by bacteria. This chart shows their development from 1930s. The blue bars shows their discovery and the time of effectiveness. The red bar shows the time when the resistant bacteria started to exist. We see that from 1916 no new drugs are developed and all antibiotics have resistant bacteria to them. So from 1916 there are many so-called superbugs or multi-resistant bacteria that kill people around the world, up to 1.2 million per year. World Health Organization has declared that antibiotics resistance is now one of the top 10 global public health threats facing humanity. Without effective antibiotics, the success of modern medicines in treating infections, including during major surgery and cancer treatments, would be at increased risk. Multi-resistant pathogens are found very often also within hospitals, and they are an acute problem. They cause so-called hospital-acquired infections. Before the COVID-19 pandemic, an estimation showed that around 15% of all hospitalized patients suffered from such infections worldwide. This endangers lives of patients and causes major costs to the healthcare system. So our work concentrated on hospital infections. In hospitals, hygiene is crucial for understanding the epidemiological development of multi-drug resistant bacteria, and this understanding also contributes to the improvement of antibiotic prescribing procedures. This helps to save patient lives, and the major way of doing this is the surveillance and infection control. Surveillance infection control is the ongoing systematic collection, analysis, and interpretation of health data. It's closely integrated with the timely dissemination of the data to those who need to know. However, back in 2017, surveillance, infection control, and hygiene got little interest. Only few hygiene experts in hospitals were working on this issue. This work got little visibility, limited funding opportunities, and garnered little public interest, as illustrated by the search in Google Trends. Moreover, the available tools for surveillance were not suitable. Epidemiologic experts worked with long lists of patients in hospitals showing their infection status, or with manually created patient timelines, as we see on the right-hand side. This required a lot of time-consuming manual work and relied heavily on expertise of the hygiene experts. And this is very highly error-prone. So new tools were needed. This was the motivation for our work. In Germany, a concentrated effort funded by the federal government was initiated in 2017, and the so-called HIMET project started. It has many important research partners, and it was driven by the infection control researchers who believed in the role of visualization. I'm sure that in other countries there have been similar initiatives. As part of this team, however, I'm most familiar with this project and I will use it as illustration for my messages in this keynote. In 2017, we were asked to develop a novel visualization for the infection control in hospitals. A 4-year project started. The computer scientists, like us, had little knowledge about the domain, the terminology, the tasks, and the data. So we needed to learn a lot about the way how they work, the goals, and also the mechanism of the infection control. In accordance with the Sedermeyer's design study methodology, we spent a lot of time with eliciting tasks, collecting data, and winnowing between data and tasks. This was a long and work-intensive process. Novel data schemes needed to be developed that matched the tasks, and the tasks had to be adapted to the available data in hospitals. We extracted 3 types of tasks. First, monitoring and retrospective analysis focused on detecting outbreaks, localizing the outbreaks, and reconstructing the transmission pathways back to the initial patient. Second, machine learning supported task was to predict infections in hospitals and to identify factors supporting the transmission. The third task was prospective. It was forecasting the future development of the disease dispersion. This is important to identify early on the disease and to isolate potentially endangered patients. For this purpose, novel data schemes had to be developed and the data had to be collected. The data consisted of patient movements, information who is located where in the hospital, and also about the laboratory tests. So who was tested and with which result. This allowed us to identify contacts between people, location of the disease, and also potential transmissions of the disease. In addition to the systems used by domain experts in hospitals, up to 2017 or 18, visual analytics research has provided many solutions for similar areas. In the area of healthcare and epidemiology, there were 2 types of systems. Simulation and analysis of disease evolution on a population level, such as Pandem CAP, or the work from Brockman and Helbig, that shows the number of infected patients, the simulation of future progress, and also the geographic spread of the disease. However, this was only on a population level without the possibility to analyze each individual patient. Other healthcare systems analyze the treatment and the progress of treatment of patients over time, such as event flow. They were not able to analyze the disease progression on individual level. So more specialized systems had to be developed. We started to work on the project and had regular in-person group meetings with the stakeholders. Along the Sedelmaier project, we designed, discovered, and implemented early prototypes and got an early feedback from the stakeholders. Here we see one of the early prototypes. We see the distribution of pathogens in the hospital, their frequency, which allows us to identify outbreak for a specific pathogen. We see the distribution of pathogens along the hospital wards, which allows us to locate the infection herd. We see also individual patients, how long they are in the hospitals, and since when they are infected. And this allows us to see the hospital-acquired infections. And we had also a first prototype of a contact network where an infected patient had contact to non-infected patients, so there could have been a transmission. Other prototypes included, for example, the patient timeline, which was leaned upon the existing visualization manually done by the experts. This timeline shows each individual patient, the start and end of the hospital. It also shows their infection status during the hospital, so for example, from when the disease started. In the end, we developed 3 visualization systems, each for one of the 3 task types. The first system addressed the monitoring and retrospective analysis. The second system tried to explain the infection transmission. And the third system was for prospective and forecasting of future disease development. The first system got the most rewards from the infection experts and also from the visualization community. This system is composed of several views. The first view is the epidemic curve that shows the number of patients in hospital and number of infections per hospital, per ward, and allows us to identify the time of the outbreak and the location of the outbreak. The second visualization shows the patient contacts, where each node is a patient, and we see the contacts between patients and whether those contacts could lead to an infection. The third view is the main view that I will explain in detail in the next slide. The fourth view is the patient timeline, where each patient is one row, and we see when the patient entered the hospital, when he left the hospital, and what was his infection status during the hospitalization. This video shows how the system could be used. Infection control expert can select words and identify times of an outbreak. Then he can look at the patients being at the ward. So in this view, each line is a patient and the color shows the infection status. The y-axis shows the location of the patient, home or hospital, and also on which ward the patient was. See the background color. So here we see that in this ward, more and more patients enter the ward, and as they enter, more and more patients become diseased. So we want to know who was the initial patient. So we can select the patient at the beginning and see whether he could infect other patients at the hospital. The automatic analysis shows that this patient could infect many other patients entering the ward. Now the question is where the disease came from, so we can search for the patient 0. Now we switch to the backward tracing interaction and trace back where this patient was infected. We see that this patient came from a different ward and had contact to an infected patient. So he was infected at a different ward by a different patient. Here we see the second system. It uses a machine learning algorithm to detect potential infections and to analyze the transmission mechanisms. We use recurrent neural networks. The result of the machine learning algorithm is shown as an extension of the previous system. Now the epidemic curve shows the true negatives, false positives, and also the potentially infected people. So the green lines are those patients that are potentially infected but were not tested. The bars on the top right show the reasons for the infection transmission. Each bar is one factor, and the larger the factor, the more it contributes to the infection propagation. What we also see is the patient timeline. The system predicts also when the transmission took place. Here we, for example, see that the patient had contacts to many other people much earlier than the infection was detected. So in the time between, he could have infected other patients. The third system is the prospective analytics. It simulates a case when one patient enters the hospital and this patient is diseased, and like that he transmits the disease to other patients. We use a Monte Carlo simulation with 1000 runs and are able to use clustering to detect typical ways of transmission. There are two possible scenarios. In one scenario, the whole network gets infected. In the other scenario, the infection is dampened. Moreover, we can see the transmission mechanism for each patient. From left to right, we see the time, and from bottom to the top, we see the patients. And here we can see which patient infected which patient and at which time moment. And like that, we can identify endangered patients and also time when the infection could affect them, so that we know how fast we need to react to the infection progression and which patients should be isolated early on. When the work on our visualization prototypes was about to finish, the COVID-19 pandemic hit the world. The 2 years between 2020 and 2022 has affected also visualization research around the globe. The next part of the talk will focus on this time period. Early in 2020, here is the figure from February 6th, the world still thought that the pandemic could be contained. Only local individual cases were found and fought by isolation. We hoped for the success as in SARS 2003 epidemic. Here is an example of the cruise liner in Japan which was isolated. From the visualization research perspective, this case resembled that in hospitals. Isolated case of hundreds of persons in a closed area. So thus, we thought that the tools that we developed were deemed suitable for such cases. We were proven wrong. Nevertheless, early on we were asked by the hospital hygiene experts to adapt our visualization to the hospital case of the COVID-19 infections. Here we see the result of a couple of weeks of work in the first lockdown. At that point of time, the question was, does the COVID also spread in hospitals? Is it a hospital-acquired infection? Now we know that this question is easy to answer. But then it was an important open problem, which was very important for the healthcare system. In the following weeks, the number of cases worldwide exploded. So did the interest in Germany and also worldwide. New research funding was released for quick response. Similar to other countries, for example, the RAMP initiative in the United Kingdom, new projects with many hospitals, large-scale projects started. We, and the whole visualization community experienced a game changer. The visualization research environment changed rapidly. When we compare 2017 and 2020, hospital infection control became a worldwide infection control in and outside of hospitals. Back then, only selected experts were interested, there was limited funding opportunities outside of public interest, and mainly with unsuitable tools. In 2020, the infection control was also outside of hospitals. There were many experts who were interested in the topic. There were many funding opportunities coming up and a large public interest. But now we also had tools. And when I say we, I mean the whole visualization community. Also, this has led to wider interest and a lot of output in the visualization research, and also a lot of output in a short time. If we compare the years 1990 to 2019, we see that there were 21,000 publications. In the 2 years between 2020 and 2022, there were already 27,000 publications in the area of pandemic visualization. The paper Mapping the Landscape of COVID-19 Crisis Visualization does an amazing job in summarizing, collecting, and organizing the works that were published in English. They collected more than 1,200 solutions and analyzed them according to the data that they show, the purpose of the visualization, and also the visualization type that was used. I highly recommend this powerful and superb publication as a reference point, also for future. Now I show a couple of examples. In the emergency response, like us, many researchers have created ad hoc solutions leveraging on their previous work. We see here an example from Afzal et al., where the visual analysis of influenza spread simulation was adapted to the COVID-19 spread. The visual analysis is still effective and useful. Likewise, many other visualizations were created also in other areas of visual computing. For example, image processing was used to create and analyze CT images of lung disease caused by COVID. A long history of BioVis visualizations for genomes and mutations resulted in the visualization of the mutations over time and also over space. This is an online visualization where we can see daily the development of the mutations. So new mutations and their spread can be monitored. Moreover, molecular visualization on mesoscales was developed to visualize the COVID-19 virus at a high precision. These were only a couple of examples from the broad variety and broad number of solutions that came up in the last 2 years. Not only adaptations and extensions of previous work, but importantly also novel solutions have been produced. They addressed new data and novel tasks. An example is the project working on simulating COVID contact tracing policies, such as how long people need to isolate, and whether any contacts of the isolated person also need to isolate. Here we see the resulting visualization after clustering of the simulated trees. Using the representative tree, we can visualize the information in the cluster using simple stacked bar chart glyphs. It shows the results of the models and effect of different policies. During the COVID pandemic, also the wider public has become the target user for visualizations. Many dashboards with updated numbers were released for public consumption. What was interesting, these were created not only by the visualization researchers, but also by the healthcare professionals, such as the University Clinic in Bonn, public health institutes such as Robert Koch Institute, and of course also visualization researchers created dashboards that could be provided to the public. This teaches us that the visualization solutions we proposed as a community now empowered users to create and deploy their own visualizations of the data of a high quality and very similar to those that were produced by the visualization researchers. And this was really needed in the crisis times. Another example of embracing new users and new tasks is found here. COVID-19 pandemic and the policy implications of lockdown affected everybody, including children. Contact reduction, homeschooling needed to be explained to them. They needed to understand what was going on. So no visualizations were born that were used to teach children how disease spread through simple visualizations of the simulations. Each node is one person, and the color says their infection status. The children could play with the simulation parameters and understand how the simulation parameters affect the spread of the disease. The work during COVID-19 pandemic affected not only our results, but also the way of working. Therefore, I would like to talk a few minutes about this aspect. The following examples are based on my personal experience. However, I believe that they are familiar to you. Many of us have faced similar challenges. The HIMET project before 2020 followed the Sedlmeier methodology with many feedback rounds. In 2020, quick practical solutions were required. We needed to provide fast solutions, thus the working time shortened, from years to months, even weeks. Long winnowing and learning was shortened, and major work was put into design, implementation, and deployment. However, the work was very challenging. Regular in-person meetings and work in small teams with close communication was replaced by isolation in lockdown. Computer scientists were isolated and healthcare workers were overburdened. We had little contact to them. There was a lot of separation. Moreover, the large interest in the systems led to new larger projects with many stakeholders, larger teams with many roles, project managers, developers, data stewards joined. Meetings of 50 people, of which we knew only a couple, were not seldom. Interestingly, a cross-check with the awarded paper Data Changes Everything from Volny et al. States these challenges in large working cooperation teams, even without additional lockdown burden. So we are not alone, and we can rename this paper COVID Changes Everything. The implementation and deployment work to many hospitals should not be underestimated. A small prototype can rise to a large system that requires interdependencies, harmonization, data exchange, and standardization. We see that the size of the visualization has not changed a lot, but the size of the system increased tremendously. Without COVID, we would not be able to do this type of work. This is not very research-oriented and not well-funded usually. Maybe this is a reason why many research prototypes never come into the acceptance and to the rollout. Now, mid-2022, we can make the first reflections on the COVID pandemic and our experiences. We can draw some lessons learned. Looking back as we started, the antibiotic resistance remains an issue unsolved and still is a global public health threat. Moreover, unfortunately, as the pandemic continues, we anticipate a significant increase in the resistance through the heavy use of antibiotics in COVID-19 patients. It is predicted that by 2050, 10 million people will be annually killed by superbugs, unless we find new treatment ways. COVID-19 and quiet pandemic are examples of recent pandemics. Many of them happened in the past, so we need to be prepared for the future. The chart shows the history of the pandemics in the last 2000 years. Here we see the time, and each dot is one pandemic. The size shows the number of cases. So pandemics come and go, and for sure there will be a new one coming up in the future, for which we need to be prepared. In line with the hype curve from the technology trigger to the plateau of productivity, we see that the basic research is important. The basic research that we do today are solutions of tomorrow. And what we also see is that research on low-profile fields can become very, very relevant for the future. Examples are the simulation analytics system by Alper et al. Or our work presented in this talk. We have also experienced the importance of enabling technologies and availability of visualization libraries. Many ad hoc solutions would not be possible without those technologies, such as D3, Vega, or Gosling, and all of them result from our research. So, not only research and prototype, but also investment to the wide use of those technologies via libraries and open source solutions is an important contribution. The crisis has forced us to be creative and look beyond the usual trodden path. We successfully embraced new tasks, such as public health policy, and identified new users for our visualizations, such as children. So crisis can be also an innovation trigger. To summarize, the field of biovisualization is getting mature. Many problems have been addressed and many effective solutions exist. So we should be proud of our achievements. And therefore, I would like to leave you with a quote from John Stasko that simply presenting data can have a profound impact. Thank you very much for your attention.